Trust Program. My name is Michelle, and I'm coming to you from Los Angeles, and I'm your host for today. Today's discussion will be moderated by the distinguished Dr. Randall Maxey, who happens to be the Chief Medical Officer of Advanced Community Medical Care Corporation here in Los Angeles. The mission of the Black Health Trust is to provide credible insights from our community of health experts to best serve our communities of color with a coalition of leading and long-standing Black medical professionals across a diverse spectrum of disciplines, and to offer unvarnished opinions and insights into our physical and mental well-being during these challenging times. So before we get started with the program, I want to share a few housekeeping items and announcements. Please be advised that this video conference is live and being recorded on different public platforms such as Facebook Live, and that participation on this call is completely voluntary. If you choose to participate on the call and prefer not to have your image and likeness displayed, there are visual and audio settings on your device that you can control to block or mute your voice. So everyone's audio will be muted upon entering the room. Initially, we ask that you remain on mute until the host or facilitator asks you to contribute in order to minimize distractions of background noise. So please check and make sure your device is on mute right now until called to speak on, and then once again, place your device back on mute when you're done speaking. We have a chat room, and if you have questions, you can enter them into the chat room, but please limit your questions to 2 questions per topic being addressed. And please do not use the forum to advertise or promote your personal products. Understand that there may not be sufficient time to get to all the questions during the call, but we'll do our best. Please note also that the information communicated on this video call is not deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice pertaining to your particular needs and situation. So here's my promo. Black Health needs you to continue bringing our community outstanding programming, critical and timely information regarding people of color in our health. Please visit our website at www.blackhealthtrust.org and learn more about programming, how you can support, volunteer, donate, and we really need your monetary donations to support the foundation of this critical information. I want to thank the Black Health Trust Steering Committee, administrative assistants, our virtual, our Zoom technician, and all the people behind the scenes for their time and efforts to make this programming possible. And we want to give a big welcome and thank you to all of our distinguished physicians and special guests today. We thank you so much in advance for sharing your valuable time, information, and educated insights with us. We're blessed to have you in your participation. Knowledge is power. So welcome again, everyone, to the Black Health Trust Program. Get comfortable, lean in, and Dr. Maxey, I invite you to begin moderating the program.
Thank you very much, Michelle. And thank you for all of our guests and our distinguished guest speakers. I'd like to personally thank each of you. Dr. Doris Brown, a fellow past president of the National Medical Association, Dr. Hayward Brown, a distinguished physician. I'm going to introduce him later in detail. Ms. Deborah Wafer, who is our special emergency guest, so to speak, because of situations that are going on. Dr. Carl Brown, who we welcome, and our own Dr. Jesse Sherrod. I'm going to ask that each person on the call, if you have social media such as Facebook, YouTube, Instagram, Twitter, LinkedIn, post this program now. It helps us grow our audience. We've had the good fortune over the past few months to broadcast to 7,000 to 10,000 people at a time. In order to expand this information to communities of color, we need your help in doing that. And we certainly invite you to become associated with the Black Health Trust. Simon, can you put up the slides, please, the first slide? Okay, next slide, please. So our total COVID cases in USA as of yesterday was 7,310,625, with there being 50,284 new cases, with a total death count of 208,118 patients, with new deaths of 816. In the US, there have been 301,539 new cases in the last 7 days. We're very concerned that this pandemic is real, but yet and still there are many people who don't believe it. From looking at TV, I've seen, despite the entire upper echelon of one political party of unbelievers being tested positive, many of them still think this is a hoax. Our purpose for existence is to give credible information to communities of color who we feel have been disregarded. We've been hit harder because of our situation economically, politically, and health-wise. And hopefully our speakers will shed light on a lot of these things. And in addition to COVID, they're the everyday things that cause excess deaths among communities of color. And we hope to explore those. Our first speaker for today is Dr. Doris Brown. She graduated from Tougaloo College in Mississippi. She also graduated from UCLA and Georgetown University. She is the president, CEO of Brown and Associates, LLC, which is a health consulting business that manages programs addressing national and global health inequities. She served as the 118th president of the National Medical Association. She is a retired colonel in the U.S. Army Medical Corps. She also retired from the National Cancer Institute, where she managed the breast cancer portfolio. I welcome NMA past president, Dr. Doris Brown, to take the floor and give her presentation.
Thank you so much for that kind introduction, and thank all of you, and especially the planning committee, for inviting me to speak, particularly on breast cancer, since October is Breast Cancer Month. And so we really want to increase the awareness of breast cancer. And if I could have my slides, and please move to the second slide. Yes, and now cancer overall is certainly a public health problem worldwide. And breast cancer, being one of the many, is one of the most commonly diagnosed cancers in women. Of course, it is the leading cause of cancer death for young women and those 15 to 50 years of age. While cancer overall is the second leading cause of cancer of deaths, breast cancer is the second leading cause of death in women, lung cancer having surpassed it a few years ago. And as I go through this and talk about cancer, we really want to focus on the fact that while the incidence, next slide, the incidence of breast cancer is lower in Black women, yet the mortality rate is much higher. And of course, we have done wonderful things over the years in taking care of breast cancer, and that is in all women. And so we now know that there are over 3 million breast cancer survivors. And so I like to really call them thrivers. They're doing more than surviving, they are thriving. And so when we look at some of the epidemiological factors for breast cancer, it's breast cancer is in terms of new cases represent 30% of all cancers, and yet it's 15% of the cancer deaths. And so over the past 10, 12 years, we've been seeing a decline in the mortality rate from the top 4 cancers: lung, breast, prostate, colorectal cancers, because we have advanced our therapies. And so we're now into providing more targeted therapies, using some of the immunotherapies. And so as we go along, we'll talk about why then is the disparity in cancer deaths, and particularly breast cancer, still there. Next slide. So what we're seeing is that for African-American women, we are 2 to 2.2 times greater chance of dying from breast cancer than our white counterparts. And so again, why is it that that is there? Now, breast cancer is not just one disease in terms of cancer. You have primarily, it's a disease of older women, and I will say women over the age of 50. That is not an old woman nowadays, because 50 is the new 30, let's say. But we are seeing that the death rate is really advancing as you get older. So 1 in 8 women are likely to have breast cancer in their lifetime. Next slide, please. The young women also have an increased risk of breast cancer, and that is usually called triple negative breast cancer. They are markers that we know to help us identify breast cancer, and that is one on our receptors that we can tell whether it is an estrogen receptor or progesterone receptor, or another one called HER2. Those receptors are identified and we group them together. And certainly for the general public, call that triple negative disease if those markers are not positive. And usually it accounts for, and I have 10 to 17% there, but we know that it can actually go up to 30% of the breast cancers that we're seeing fall into that triple negative cancer group. It is a very aggressive cancer, and it tends to occur in younger women. And so it is distinguished from the postmenopausal breast cancer. And of course, we've been using the age of 50 as the cutoff for premenopausal and postmenopausal. And so this is a disease that we tend to see in younger women. And of course, it tends to be a very aggressive cancer and will recur even if it responds to treatment. Next slide, please. Some of the risk factors for this triple negative cancer is that you have to be young. As I say, generally they're younger than the age of 44. They're African American, and also they have the BRCA1, which is the gene mutation for breast cancer. And when you have that with the young age and African American population, your risk tends to go up quite significantly. Some of the distinguishing features of this is that it puts you at a higher risk. And we also know that all women, if you have the BRCA gene, you're going to be at a higher risk of getting breast cancer. Usually you see that in more Ashkenazi Jews, but we're beginning to see a significant number of that mutation, as well as other mutations in the African American population. It doesn't usually matter where this cancer will occur, but we know that it has a tendency to have a spread from a metastatic standpoint to our brain. And it has no correlation in terms of whether your nodal status is positive or negative, or the stage that you get the disease. Next slide, please. I've listed some risk factors here, which are many things that you can't modify. And so I'd like to just focus on the things that you can modify. We have to look at from a positive standpoint what you can do. And those generally fall into the category of the lifestyle factors that we can modify, whether we are active in terms of exercising and mobility, whether we are watching our diet and whether we have alcohol there, or whether you're taking in some of the hormonal products to help us with hot flashes and some of the other things that's there. Next slide. So just looking at, and again, I've sort of put in the summary here from the triple negative breast cancer. And one of the things that is really important, because we're learning about triple negative breast cancer, there's no specific treatment for triple negative breast cancer. It is important for women to participate in clinical trials so that we can gain the knowledge that's going to help us as we advance this disease in the future and take control over it. As I've heard from one of the introductions, that knowledge is power. And so we certainly want to have power. And in order to do that, the information that we're gathering from clinical studies helps us to know what is specific for us. And that's why it's important to participate in those studies. Next slide, please. One of the things that came out of the Association for of the Society for Clinical Oncology, it was a recommendation because we can test young women for the BRCA1 mutation, and it really is a very cost-effective strategy to utilize. But many insurance companies certainly did not want to pay for that test, particularly in African-American women. But as I've indicated, you're at increased risk if you have that, particularly if you have a family history of breast cancer or you have had a prior breast cancer. It's important to really know your history, know your family history, and then to get that BRCA1 genetic test to determine where you stand in that. Next slide. Just to mention a little bit in terms of screening modalities, because there's been lots of controversy for Black women in particular with getting mammograms. We know that a mammogram is one of the best tools that we have for the detection of breast cancer. Breast clinical self-examinations, while many women find, and a large percentage, I would say in the 70% in the patients that I was seeing, detected that lump themselves. Annual clinical examination certainly adds to that. But a mammogram can locate that lump that's in your breast really very early on. Again, controversy come out because the American Cancer Society, the American Society for Radiology, and the US Public Health Task Force all have different recommendations as to when you should start getting a mammogram. One says you should start at age 40, another one says age 45, and of course the US Public Health Task Force says you should start at age 50. Well, what about all those women that have triple negative breast cancer that's younger than that? So they're too young to get a mammogram by the standards. And of course, if the insurance companies are basing their discussion on this, then they would not pay for that mammogram. And so again, a lot of it is left up to the individual and their physician to determine what age to start getting a mammogram. And I certainly will say for African-American women, it is for you to have that discussion with your healthcare provider and then make a decision that's based upon your clinical and your family history as to when to start getting that mammogram. Next slide. Looking at some of the things, and this is taken from ASCO in terms of the treatments that we've moved into. And I just wanted to point out that even with triple negative breast cancer, we're getting some of the newer immunotherapies that are available. And of course, we are beginning to see a response to the triple negative breast cancer, because while they respond initially to the chemotherapies, it is not a durable response, and they tend to relapse and have metastatic disease. Next slide, please. So one of the things that really is important is for us to focus on prevention. We haven't talked enough about prevention. Next slide, please. And this goes back to even the Hippocratic Oath and things that's there in terms of really how important it is for us to think about a prevention. And so there have been studies that we have done and agents that's on the market that we never talk about that can prevent breast cancer in postmenopausal women. One is tamoxifen and the other one is raloxifene. Again, we don't hear very much about that in the primary care provider's standpoint. And so it's really not utilized to the level that it should be. Next slide. So what we are getting to now is really looking at those behavioral things that we can do on an individual basis that will help us to minimize our risk for breast cancer. And one is eating a healthy diet. We talked about this in the past, but we tend not to really focus on that. You want to have a diet that's going to be high in fruits and vegetables and whole grain. And you want to try and stay away from those high nutrients, high energy, kilocalorie kinds of foods. You want to take away or minimize to a great extent having red and processed meats in your diet. And of course, we all have heard about the sugar sweetened beverages and sugar in general. There are many things that we don't even think about and we use every day that has sugar in it that we haven't thought about. Things like your toothpaste, it has sugar in it. Ketchup, has sugar in it. And again, we want to minimize those kinds of things and certainly stay away from the processed foods and those things that you're buying in the fast food industry. The other thing is to increase your activity. Now, given that we all have COVID and we're staying in, but we can all go out and walk. We know that our gyms are not as full as they have been, and there's certain apps that you can get on your smart devices. Those things will really help you. We'd like for you to have 300 minutes of activity. That's about an hour a day for 5 days a week. That is the optimal thing. But even if you did 10 minutes a day, it's going to be very, very important in terms of preventing cancer. And the other one that give us a lot of controversy is reducing or omitting alcohol. Now that we've been closed in, and I'll just show you some of the data, things that we've had following COVID. We're drinking more, we're eating more, and we're having more of a sedentary life because we are sheltering in place, and that is not the best thing for us. Next slide. Obesity and cancer prevention. There are 13 cancers that we know of that is directly associated with obesity. And Americans, particularly adult Americans, have really a high obesity factor in terms of their cancer risk. And some of those things is obesity tends to be linked to inflammation. And as a scientist, inflammation is one of those key factors that we see in a number of disease categories. Insulin resistance, and of course, insulin resistance tends to add to our gaining weight. The suppression of our immune system, and I'll come back to that in just a bit because it ties in with COVID. Oxidative stress and damage to DNA, all of those things affects and impacts our immune system. And again, adds to the obesity and adds to those cancers that really is going to lead us to having a poor health outcome. Next slide. So let's talk about COVID. Since COVID has been, and of course, breast cancer being that feared disease that women really don't like to talk about, it has a tremendous emotional impact. But since COVID has been in the forefront, we have seen a decrease in people getting their mammograms by 62%. 25% decrease in those that are getting genetic testing. So we don't know whether they have the BRCA1 or 2. And for the breast surgeons, and I don't know if we have a breast surgeon that's on the call, we're seeing a decrease in the surgery that's related to breast cancer. So overall, we are seeing a decrease in the number of new breast cancer cases by 52%. Now, we know breast cancer didn't go away in this past 7 or 8 months since the pandemic has been here. But those women that may have a sign are fearful of going in because of COVID. And so they don't get their mammogram. They don't go in for their annual exam because they don't want to be exposed. And again, we have to then really increase the knowledge that it is important that you maintain your healthcare preventive steps to make sure that you are going to minimize getting advanced disease. Because when we look at breast cancer and the difference into why we have a higher mortality rate in African Americans, many times it's because it's late stage of diagnosis. And we have that late stage because we did not find that lump. We didn't have our mammogram. We didn't go in for our clinical exam. And the other factor is, as I've indicated, because of COVID, we tend to see an increase in our alcohol consumption. Whether you used to have maybe 1 glass every few days, now you may have 2 or 3 glasses a day. And that is increasing your risk because alcohol has an impact upon the estrogen that you're putting out, and those receptors then increases your likelihood of getting breast cancer. Next slide, please. So what is it that we can do as healthcare providers? Next slide. Yes. As clinicians, what we want to do is we don't really talk to our patients very much about monitoring their weight, about the importance of exercising, the importance of engaging their family members on terms of what is appropriate of their health behavior. And you can actually write, and I remember Dr. Satcher, when he was Surgeon General, used to give a script to the patients to exercise. And I think that's one of the things that we have gotten away from. But as clinicians that's taking care of people of color and underrepresented populations, we need to really be very active in making sure that we refer those patients to wellness programs, that we encourage them to exercise. And then we want to really get them involved in support programs in their community and actually serve as a role model for healthy behavior for individuals so that we can have a more positive health outcome. And yes, the breast cancer new cases will continue to go down, but it is a real going down and not one because we're fearful for going in and getting our screening. I want to thank you. Next slide, please. I think that was my last slide. Thank all of you. I'll be happy to answer any questions.
Dr. Brown, we certainly appreciate your thoughtful and astute presentation on breast cancer. And I salute you as a full bird colonel in our U.S. Army. Several questions, and we'll look in the chat box in just a moment.
Okay.
But you related many instances of breast cancer and cancer in general to obesity. And I'm aware that more than 65+%, if I remember the numbers, of Black women are classified as overweight, if not obese.
Yes.
Can you just speak on that a moment in a cautionary way to our population? I recall that many of everybody I knew at my church that I call Aunt Sadie, Aunt whoever, they were all healthy and cheerfully obese. How has that changed?
It's a very slow change. While we go to church, we have a coffee hour after church and we serve that unhealthy food. It adds to that. And of course, we think that having there was a saying, the bigger, the thicker, the better you like them, which is really, we need to get a saying that it's not the bigger, the thicker, the better you like them, but getting one that is going to embrace healthiness. And so while, yes, we don't want to call a person obese, we want to say that you want to be a healthy size. And so I think what one of the slides was saying is that we really want to encourage our primary care providers to encourage people to eat a healthy diet, to get them into a wellness program. And many of our systems nowadays have a healthy program that you can get even online. There are food demonstrations, because many times people are not aware that, oh, I can fix quinoa and that's healthy for me because it's high in protein. You say, oh, I don't know what that is. It's something that I don't want to have on my diet. I'd rather have some white rice. Well, it's just sort of substituting some of those things and really encouraging those women to still be healthy and happy. But obesity is tied to cardiovascular disease. As I've indicated, there's about 13 diseases that will go along with that. And so getting away from the heart disease, the kidney disease, the diabetes, I mean, the chronic diseases are there and associated with our dietary factors. And then you add on top of that, that we sit at our computer, we sit in front of our TV. We don't want to get out and have the kinds of things that my parents had, whether they had to get out and work on the outside with carpentry or in the fields and that kind of thing. We tend to alter our life. And so we want to encourage all of our patients to let's try to minimize that waste, but not so much in terms of getting, we have fads and our young people like to get on a fad diet. It's keto this week and it was Atkins a few years ago and some other diet. You want to just start off with children eating healthy foods at a young age. And then that builds into a healthy habit. And then you don't have to worry about it so much when you get to be Aunt Mary and Aunt Sue at church.
Well, thank you, Dr. Brown. Michelle, is there a question in the chat box for Dr. Brown?
Yeah, yes, there are several. And thank you, Dr. Brown. I 100% agree with starting off the children with good eating habits early and developing those good eating, healthy habits, lifestyles. So that said, how does the general public become aware of or connected to clinical trials specific to breast cancer?
For all clinical trials, it's thank you so much. Very important question. Cancer.gov is one site that you can go to. It's on the computer and it has clinical trials that's listed, or clinicaltrials.gov, GOV is gov, has all of them listed under by the disease category. You can also ask your provider and they should be able to assist you. Also, the pharmaceutical companies have a number of cancer clinical trials that's there. And so breast cancer support groups, since we all should be a part of and have that, because you need the emotional support. You can't go through this disease alone. You have your significant others and your children and other family members, but also a support group is really important. And there are a number of resources. The American Cancer Society, the National Medical Association, the American Society of Clinical Oncology, all of them on their websites have clinical trials information and you can get it there. But if you want to make sure it's a trusted agent from somebody that you know and you want to go through what are the eligibility criteria, then you want to deal with people that look like you. You want to make sure you go to those resources, whether it's at our HBCU medical schools or clinics that our providers are working in.
Michelle, I'm going to ask you to let's save some of these questions because we got a full schedule and I want to have them come back to the panel in general. Just briefly, before we leave Dr. Brown, we have set as a mission for the Black Health Trust that we not only present information that's credible regarding health disparities and COVID, but we also are trying to showcase and present Black physicians so people will know that in our community we have credible experts. And I'm wondering if in 30 seconds or less, you can talk about this organization that you were recently president of.
Well, the National Medical Association is near and dear to my heart, and I hope that all the providers that's on are members of the National Medical Association. It is 125 years old, and again, it has 26 subspecialty areas, and we cover health care for all individuals, including physician executives, as to how to maintain your practice. We have 6 regions throughout the country. And again, you can find anything that you need at the National Medical Association. And we collaborate with a number of other programs. We're concerned about Black men in medicine. We have the Student National Medical Association. And speaking on clinical trials, and I'm staying under my minute, is the Cobb Research Institute that is a part of the National Medical Association, actively engaged in a very large 1 million participant study with the National Institutes of Health called All of Us. And again, we are recruiting providers as well as individuals to become active members of the clinical trial. And that's a population study data to answer why is it that African Americans die more from this disease than others? And it looks at the environment that you're coming from and genetics, and it's data collection. And you too can become a participant in that study, also as a research participant. So go to joinallofus.org and sign up.
Well, thank you so much. There are a number of your other colleagues, past NMA presidents, Dr. Ron K. Bailey, Dr. Richard Williams, Dr. Rodney Hood,
Dr. Randall Morgan.
Dr. Randall Morgan, who've been on this program. So we appreciate your participation. Let me introduce the next guest, and hopefully you'll be around for questions in a few moments. I'd like to introduce Ms. Deborah Wafer, who's been a friend to the National Medical Association. She works for a company by the name of Gilead. And given the recent health events of a large 250-pound plus gentleman that they also call POTUS, and he was given as a part of his treatment plan a certain drug, and I thought it was very important that we have some idea of what this is, and I'm going to ask her to speak about it. She currently works at Gilead Science, and she is a medical scientist. In this role, she provides healthcare providers on PEP and PrEP, and on the other modalities. She has also worked on the Gilead community marketing team. She is a marketing professional. She's demonstrated great expertise, and she works for a pharma organization. We normally like to say big pharma is the root of all evil, but they also provide a lot of serious treatments for some of these problems we have. But because she's been a trusted friend for years and years, we're going to invite her. I recall recently I was consulting on a patient in Mississippi. They called to consult in about 11 a.m. And she was 35 years old and she weighed 450 pounds. And they told me that a certain medication was not available in Mississippi. I called this young lady, and within an hour or two, she had the medication on the way from Ole Miss, the university, on the 3-hour drive to attempt to treat that patient. But I'd like to introduce a friend of our community, a member of our community, Ms. Deborah Wafer. Would you please give your presentation?
Oh, thank you, Dr. Maxey, for that warm welcome. And thank you, Black Health Trust, and good afternoon, and good, I guess it's good evening for some people too. Coming to you from Los Angeles, and it's interesting what people say about Big Pharma. And you know, before I came into the business, I didn't know really what pharma was all about. And now that I'm in, you know, I kind of feel like the spook who sat by the door, right? There's all kind of stuff to learn, and there's all kind of opportunities that I think we as a community could learn more about, because clinical trials and data gathering and the lack of those things, as Dr. Brown just talked about, is what we need more of. So with that, I want to just give a brief overview of Gilead Sciences Remdesivir program. And as many of you may know, the POTUS received Remdesivir the other day, and right now it's the only standard of care, or the only drug that's been approved for COVID-19. And it is given intravenously, and it's usually given for 5 days. So they keep talking about the president's coming home, but unless they're going to give him his IVs at the White House, he'll be there until he gets 5 infusions of remdesivir. So with that, what I hope I can accomplish today is talk a little bit about compassionate use, expanded access, and emergency use authorization, and how those are all different, because I think that there's been some miscommunication about that. Are my slides up and I'm not seeing them?
I think they're on their way.
Okay, I was stalling there. Okay.
There we go.
All right, thank you. So first, talking about remdesivir, and what Gilead really wanted to do was to establish the safety and efficacy of this drug, and then scale up the manufacturing, and then make sure that it was accessible for people. Now, we didn't have to start from scratch with remdesivir, because it was a drug that was already being looked at for the treatment of Ebola. I never know how to say that. Anyway, there were patients who received some of this drug, or a drug like this, for Ebola. And so Gilead already had this on the shelf. And so we didn't have to start from the beginning. And when we looked at it, we thought it would be something that would be possible for people living with COVID-19. If you go to the next slide, please. So we had Gilead had some foresight. We were thinking ahead, and we put together a task force that started planning before WHO declared COVID-19 a pandemic. And we wanted to evaluate how remdesivir worked with this virus, and then scale up production. And so there are a couple of phases that we went through. First, we had to look at the production time. How long would it take? And we were able to decrease that time from 9 to 12 months to 6 months. And then you need the material so that you can get the drug out. And in January 2020, Gilead began globally sourcing several critical materials that were needed to make this drug. And then we moved to increasing the production. And by February 2020, remdesivir supply from the Ebola efforts were transported from Edmonton and moved to our manufacturing facility in Laverne, California. The headquarters, just so folks are not confused, for Gilead is in Foster City, California. And I describe that as it's between the San Francisco airport and Stanford. And so Laverne is just one of the sites that we had. So we were thinking ahead, and we really wanted to see if this was something we can do. And like all the other things that have happened around COVID, we were able to shorten the timelines for the efforts to get moving on this medication. And if we move to the next slide, it takes a look at Gilead's response and the collaboration that we did with remdesivir. And basically what we did was, there was a donation of remdesivir. We had medical education programs. We worked with NIH and supplied drugs for global trials, as well as trials that went on in China. And we also worked with Roche Pharmaceuticals. And in the meantime, we were working with the government and different regulatory programs to make sure that we could get the drug out. And the case that Dr. Maxey referred to in Mississippi was a case where we were able to get the drug out in an expanded access effort, because before that, we were giving the drug away on compassionate use. And with compassionate use, those are one-offs. You have to present your case, Gilead has to look at it, and it has to be approved. So when the epidemic first started, that was okay because they were just one-offs. And then we became overwhelmed. And because of the number of requests that we got, we moved to an expanded access program. And then in May of 2020, the FDA issued an emergency authorization for the use of remdesivir for the treatment of patients who were hospitalized with severe coronavirus. And if I could just take a minute, in the middle there, we have clinical trials. And some of the first trials were started in China. And that's because that's where most of the cases were. But also that's where people were really, really sick. And so some of you may remember that there was a publication that came out and talked about the trial was stopped. And the trial was stopped mostly because they stopped having as many people enter the hospital in China because of all the other shutdowns and sheltering in place things that they did. So that study was stopped. And then Gilead continued to do studies in the United States. If you move to the next slide, I'll just spend a minute here just to let you see some of the things that Gilead did in the timeline that they were done, looking at how compassionate use happened January, February, and then in March, there was the trial started, and the simple severe trial was for people who were really sick, and that was the trial that was done in China. And then there was a trial that was started for moderately ill people, and then the whole expanded access program started. And there's still lots of stuff going on, and we're still collaborating with other companies and with NIH and WHO. And if we move to the next slide, this is just, again, talking about compassionate use. Oh, can you put that in slide mode? I don't know what's going on there. Is it possible to look at that in slide mode? Okay, so as I said, with compassionate use, that was started, and that was for individual use, and that was also one-offs. Once we became overwhelmed, we moved to an expanded access where we wanted to collect data on all the patients that the drug was going out to. So there wasn't necessarily a clinical trial, but you needed to know the demographic data as well as where the patient was located, if there were any other important time points that needed to be discussed regarding this patient. And then we wanted to make sure that the drug was safe, that it was working, there weren't huge side effects. And then we moved to the emergency use, and this is where we are right now. We have emergency use, and Gilead has given the drug away to the federal government, and they're deciding who gets the drug. Actually, the drug goes to the health departments, and then the health departments distribute the drugs to the hospitals and the agencies that need it. We go to the next slide. Just a little bit of information on where you can find more information about remdesivir. You can go to remdesivir.com. Gilead is working with key stakeholders so we can learn more about where the drug is most efficacious and if there are other studies that can be done. We're doing what we call investigated research support studies, where folks may be looking at things like HIV. Are people who have HIV, do they have less COVID or do they have more COVID? And I can tell you right now from what we've seen, having HIV does not make you more susceptible to COVID-19. And there is some data that suggests that some of the HIV drugs may actually act as a protective against COVID and probably because of their whole antiviral effect on people. And if we go to the next slide, we can take a look at, I don't know why this is coming up like this. Anyway, some of the other things that are going on, some of the philanthropic funds and how what Gilead is doing in terms of donations around the world, as well as our access program. And our access program is really committed to making sure people who need the drug get the drug, no matter what their financial or their insurance status is. So if someone needs the drug, it should not be a question about if they have insurance, if they don't have insurance, if they can afford it or not. Gilead has programs making that available. And then the other thing is that we're working on telehealth practices and making sure that we're answering those questions that people may have about remdesivir. And I would just like to end with one of the other things that we're doing is we're working on looking at an inhaled version of remdesivir, so that it's something that could be started before people get to the hospital, before they are severe or moderately ill. And so far, 2 weeks after we got FDA approval, we kicked off a phase 1 trial to look at inhaled remdesivir in 60 individuals, 60 healthy individuals. So we hope that with reformulating this so that it can be inhaled would make it more accessible for people on an outpatient basis, and hopefully we could start treatment earlier. So with that, I'll end there, and if we have any questions, maybe I can take a few of those now.
Thank you so much. I appreciate your presentation and your dedication. Michelle, is there a question in the chat box?
I'm going to read this one. It says, first, people were paranoid or concerned about taking the vaccine. And now that we have more information as the months have gone by, people are more receptive to the vaccine, to taking the vaccines. Do you have any particular concerns that the vaccine may be hoarded or withheld from people of color, as it were, and distributed to maybe the wealthy or, any particular caste or hierarchy, and who will actually be able to receive the vaccine if we all did decide we're comfortable with taking it? Is it going to be harder to get for people of color?
Well, first of all, remdesivir is not a vaccine. Remdesivir is a treatment, and it's a treatment for people who have COVID-19. And as we know, vaccines are given to prevent the illness. And Gilead is not in the, we don't have a vaccine that we're working on. And so let me just clear that up first. Gilead is not working on a vaccine, and remdesivir is not a vaccine.
Okay, so if we replace vaccine with remdesivir.
Okay, so if you replace, I just want to make sure we're clear on that. And okay. And there is no vaccine yet for COVID-19. And if you're asking about, will people have access to remdesivir? People do have access to remdesivir right now, today, if they need it. And I don't think that there will be any hoarding. I think what will be, could be a potential issue is if, when we look at flu season and more people might be diagnosed, will there be enough drug available? And that's why I showed you in the beginning of the slides how Gilead was trying to scale up, and we've been able to cut down the timelines for manufacturing the drug, so that, there was a bit of flying the plane and working on it at the same time, right? Trying to get the drug out to people who needed it, who were coming into the emergency room severely ill. And now we want to look at treating those who come into the emergency rooms or come into the hospitals who are severely ill and moderately ill. It's been approved for both categories. And then we're looking at, for folks who might have mild symptoms, if we can move the drug so that it's inhaled before people come into the hospital.
Okay,
Yeah, I
Thank
hope
you.
that answered the question.
Thank
yeah,
you so much, very much. I appreciate you. And if you can stick around for questions.
Okay.
Our next speaker is Dr. Walker still available? He sent me a note that he had an obligation. Is Dr. Walker still on?
Yes, I'm here.
How are you, sir? I appreciate your patience.
Nope.
Dr. Walker is a urologist, and I don't have your bio in front of me, but I have read it. And you are a world-class urologist. And in 2005, after I was NMA president, I had to be treated for prostate cancer. And it generated a lot of anxiety in me, starting from the first place, I didn't even want to have the exam for it. So I was hesitant and I didn't want to have the treatment for it, but I did. And years later, I'm doing fine. But I appreciate you being able to present the issues of prostate cancer, especially in Black men and especially during COVID. Please take the floor. Thank you.
Thank you, Dr. Maxey, and thank you for that introduction. First of all, I just want to thank the speakers before me. I enjoyed your talks. To Dr. Brown, very special honor and privilege to hear you speak. I am the president of the R. Frank Jones section of the NMA now. So I'm obviously always happy to hear, and to be able to speak with past presidents of the NMA. So with that said, I'm going to spend a few minutes just talking about prostate cancer. It's not immediately relevant, I think, to the topic of COVID, but I think that it's important to make sure that we are, really sort of maintaining the standard, so to speak, in terms of the care of the many other diseases and illnesses that affect our communities as we deal with this much larger issue, because as I think many of you have probably seen in your own practices, and also to the audience, there's a lot of conditions that are still very important and relevant that we really can't let them take a back seat. So I'm pleased to speak about prostate cancer for a few minutes and just kind of try to keep it in the forefront. So if I could have my slide reel up, I will start. Okay, excellent. So as I said before, I'm going to speak about prostate cancer. I'll take the next slide. Okay. So you will see some similarities, I think, as we speak about prostate cancer, and we look at some of the numbers here with respect to the outstanding presentation we had from Dr. Brown, but a lot of the same issues apply here. So just generally speaking, prostate cancer is an important cancer. It affects 1 in 6 men in the world, and is the second leading cause of cancer death. It is important to keep in mind that it's a slow-growing cancer, and it typically affects men who are older, typically over the age of 65. And the truth about prostate cancer is that the great majority are indolent, meaning that they are not aggressive, that they are not necessarily cancers that will kill you. But about 15% are aggressive. And if we kind of look at what that means in terms of the overall epidemiological burden, that ends up being a lot of men. And so, some 35,000 men will die a year. Some 240,000 men roughly will be diagnosed. So those are pretty significant numbers. The symptoms of prostate cancer typically occur only in later stages of disease. And the reason that's relevant is that it's a cancer that often can go undetected. So we may not know that cancer is present just based on assessing symptoms. And so we have to find other ways to detect the disease. And we'll speak about that in just a minute. So we're going to turn to the next slide, but in a minute to talk more obviously about race. Actually, if we can just, I'm sorry, let's go back to the last slide just for one moment. We'll speak more about issues of race on the next slide. That was my point. But before we get to that, general risk factors for prostate cancer include age, African-American race, family history, and then, diet and lifestyle factors similar to breast cancer. So this becomes a very common recurrent theme. Red meat, high intake of red meat, meat products in general, fattier foods, all of these common risk factors that we see with so many of the cancers that affect our communities. And lastly, I just want to say that, the things that are important with prostate cancer are the same as those issues that affect and determine the prognosis for all cancers. And so what's the stage of the disease at diagnosis and how aggressive, what's the grade of disease? So what's the biological aggressiveness of that cancer? And also the treatment and are treatment options available? Are they appropriate and are they timely? So we'll talk more about that in just a moment. So now I'll take the next slide. So let's talk a little bit about the issue of prostate cancer and race. So although it is largely a cancer that may not kill people and which can be treated, it is very significant for African Americans. And when we look at the numbers, what we find is that the incidence of prostate cancer among Black men is about 2.5 times that for their Caucasian counterparts. And that's obviously very significant. But I think what really is important is that there are, we need to sort of look at what the reasons are for these disparities. And again, it comes down to the very similar issues as those we heard in breast cancer. And what we find is that disparity is largely due not to the disease itself or the biology of the disease, but to socioeconomic factors. So things like access to care, insurance status, whether you are in a community that has appropriate representation of urologists. And there are issues of bias in terms of how we make the diagnosis and how we counsel our patients. And so when we look at these social ills, we really find what's at the heart of that disparity. And I won't be able to spend much more time speaking about that. That's for me, that's usually a whole hour-long talk. But what we find is that if, when you sort of even the playing field and when you actually, diagnose Black men at earlier stages and you offer them the standard of care in terms of treatment, you find that their survival approaches 100% at 5 years. That survival rate drops to as low as 30% when they present with disease that's already spread. And very often, unfortunately, that's the case. So that's a pretty staggering number there. Next slide, please. So, the most important thing that we need to think about when it comes to, making the diagnosis of prostate cancer is screening. And this is also another topic of controversy, and I won't be able to get into the whole controversy, but there was a period of time not that long ago when United States Preventive Services Task Force was recommending against routine screening for prostate cancer. And that has very much fallen to the side at this point. The American Urologic Association, the American Cancer Society, and many, many other, the NMA, the R. Frank Jones Urologic Society, many, many, very highly respected organizations that are firmly rooted in scientific evidence have really come out firmly to say that screening has to be done. And in particular, it has to be done for Black men. And one of the problems with that recommendation is that it was looking at very large data sets for which the representation of Black men was very low. And so it said very little about how this disease actually behaves in the African American community. And so now the AUA says that, again, their language is not as decisive as ours is for the R-Frank, where we say that African American men must be screened over the age of 40. The AUA does acknowledge that high-risk groups such as African American men should be offered or should have some discussion about screening beginning at age 40. So that's really important. That was an important endorsement. If you go to the next slide, I'll show you the American Cancer Society's recommendation. Next slide, please. So this is what came out from the American Cancer Society. And this was similar, except that it used 45 as a cutoff in which to begin screening for African American men. I think that, again, we prefer age 40, and there is evidence to support that it should start at a younger age, but certainly 45 is better than what was the potential outcome of the USPSTF's recommendation. Next slide. So just briefly, the screening for prostate cancer involves both a digital rectal examination, or DRE, in which we actually examine and palpate the prostate. So we have to feel the texture of the prostate to determine if there's risk for cancer. And also a blood test called the PSA, which I think I had on an earlier slide, which stands for prostate specific antigen. So those are the two tests that are done for screening. And if we find based on those tests that you are at risk, we will recommend a prostate biopsy. And really, this is the only way to make the diagnosis of prostate cancer. You have to actually obtain tissue that can be looked at by the pathologist. So this is a diagram of how that's done. Next slide. So, the issue behind treatment is of the utmost importance, or I should say the issues behind treatment are of the utmost importance. And essentially what we know about treatment is that we really need to offer treatment when people are in earlier stages of disease, if possible. We have the best outcomes. We should keep in mind that because most prostate cancers may be slow growing, if men are older and have limited life expectancy, we probably should not be thinking about aggressive treatment protocols. But for other men, younger men, men who are in good health, we absolutely should be prepared to offer curative therapies. Now, the one point that should be made with respect to that is that even among younger men, if we find evidence that disease is likely to be indolent, there are opportunities to put people on what's called active surveillance, where we actually will watch them very closely, check the PSA at 3 or 6 month intervals, and offer repeat biopsies every 1 to 2 years. So that's a protocol that we call active surveillance. We have to really do this with great care when it comes to African American men, because it seems that there's a lot about this disease that may not fit some of the protocols that we've looked to in the past to guide us with respect to active surveillance. So we have to be very cautious and careful. It can be offered under the right circumstances, but I think we have to be very careful about that. Next slide, please.
I'm on a broadcast right now. Can I call you back?
So I'm going to just so that I don't run too much longer, I'm going to wrap up with the next 2 slides. This question was actually brought up in the course of me putting these slides together. It's really important to understand that there are potentially very significant side effects of treatment. And these side effects tend to affect a man's sexual and urinary function. And so erectile dysfunction is a very prominent side effect after treatments for prostate cancer. As many as 60 to 70% of men can be affected by erectile dysfunction after prostate cancer treatments. And there are a number of other things here which I've included in this list, including loss of length, problems with ejaculation, urinary incontinence, and other urinary symptoms. Next slide, please. And so, you know, there are many treatments, and we won't go into these in any detail, but it is important to know that for sexual dysfunction in particular, as well as the other complications that I brought up, there are many treatments that have been demonstrated to be effective. And it's particularly important when counseling, you know, African-American men where culturally there may be a real fear of undergoing treatment for prostate cancer that relates to the issue of sexual dysfunction, that there are treatments, and that fear of this complication should not prevent one from being screened or from having a timely diagnosis and treatment, because these things are, you know, this is a potentially life-threatening disease, Black men, and it can be cured. I'll finish on that note. I do have a summary slide at the end here. If you want to take it to that slide, that's fine. But I think I'm going to go ahead and wrap here and just reiterate that you know, it's really important that we have early diagnosis, that men are screened, and that we offer the appropriate curative therapies when men are eligible for those treatments. Thank you.
Thank you so much, Doctor. We really appreciate your presentation. I hope you have time for some questions. Dr. Nabors-Stevens, are you on?
Yeah. Do you want me to?
We'll have Dr. Nabors-Stevens is my co-moderator.
Okay.
Here.
Do you have a few questions for the doctor?
Yes, we have several questions. This is an area that a lot of people are hesitant to approach. What would you say is the most important thing that the African-American male should do in terms of taking care of their health, and specifically their prostate health? You know, Black men tend not to take care of themselves as well as they could. So what would you say is an absolute that they must pursue?
So I will speak in the collective and say we, because this is obviously something that affects me, and I'm in that age group. And so what I will say is that we have to go to the doctor. And one of the things that concerns me is that, you know, these recommendations that came out about screening a number of years ago have led many primary care doctors to be a little bit less vigilant about screening because they're still following those guidelines, or there is some after effect of those guidelines. And so it's really important for African-American men to know that we have to be screened. And if we are not being offered screening by our own doctors, we have to find resources that are available to us, and there are many. You know, the R. Frank Jones, for example, you know, every year at our meetings, we talk about screening. We often will do screening events at the sites where we hold our annual meetings. But there are many different free screening programs that can be offered. So you have to go to the doctor. You have to inquire about screening, about the PSA test. You have to be sure that you are getting it done after the age of 40, even if it has not been recommended to you. And that's extremely important. And what I find is that a lot of my Black patients just don't know that.
May I ask a question, Dr. Neighbor?
Yes, go ahead.
I've had a recent phone call from a patient. He said, "Doctor, I'm calling for a friend of mine, and he has diabetes and high blood pressure, and he's having difficulty getting and maintaining an erection. It's not me, but for my friend. Can you tell me what options he has?"
Yes. So, you know, that's obviously a topic that goes beyond just prostate cancer. But, you know, the first thing is really you should be evaluated, you know, by either a urologist or a primary care doctor that has some either expertise or interest in men's health. And so you need to undergo a thorough evaluation because we have to understand what the causes are. So that's really important. And you mentioned diabetes. Obviously, it's very common to find erectile dysfunction in men with diabetes. Once we have done that evaluation, we typically will recommend that you start treatment with a medication like Viagra. So there's a class of medications, including Viagra, Levitra, and Cialis, that are very effective. They are the first-line medications, and they are generally safer than most people perceive them to be. There's a misconception in the public that these are dangerous medications, that they're dangerous for your heart, which is not actually true. If you have heart disease and you take nitroglycerin or nitroglycerin-containing medications, then it can be dangerous. But for most men, these medications are actually not dangerous. That being said, I don't think that you should have these medications prescribed to you by people online or from mail-in pharmacies and things of that nature when you have not had an evaluation.
All right, thank you very much. Let's take one question from the chat, if we could, Michelle.
Okay. The question is, what is your opinion about finasteride usage over a long period of time and its relation to prostate cancer?
So this is a great question, and it's a fairly involved one. So I'll try to keep it short. There is no compelling evidence that finasteride increases prostate cancer risk. For some period of time, we thought that there was a benefit to taking finasteride in terms of reducing prostate cancers. And what we found, and then actually, so there were studies done, and the outcome of the long-term follow-up of those studies actually showed that there was potentially risk of higher grade or higher risk prostate cancers as a result of being on the medication. And what we've ultimately found is that finasteride reduces the size of the prostate. And in so doing, we believe that it increases the ability to detect more high-grade prostate cancers. And so it doesn't actually cause cancer. It doesn't cause higher grade prostate cancer. It doesn't increase one's risk for higher grade prostate cancer. But I actually do like it in some ways because it improves the ability to detect the disease. So in people that have a higher PSA and a large prostate, I like to actually use the medication to reduce the size of the prostate to then have a better efficiency when it comes time to do a biopsy in terms of actually detecting the disease. So I think there is some benefit, diagnostically as a provider, but as a patient, there is no increased risk per se to being on the medication.
Do we have time for her?
Dr. Walker, I understand that you need to leave, and there's a lot of interest in men's health, and I hope that you will be able to return to us in the near future so that we can continue this conversation around men's health. And we want to thank you so much for your comments this afternoon. Now, if you can stay, we'll be more than happy to share some more questions with you at the end of the presentations. But if you have to leave, we understand.
So I first of all, thank you so much for the invitation. I actually would love to come back and talk more. And I'm sorry that I have to leave early. I'm actually on call today as well. So there was an issue I had said I would deal with after 4 o'clock. So I do have to go, and I apologize for that. But the next time I will make sure that I have the full 2 hours to be available for the whole program if you care to invite me back. So thank you.
Thank you so much.
Thank you. Appreciate you.
All right. Have a great day.
You
You
too.
too.
Bye-bye.
Now we are going to move forward in our speakers and ask Dr. Haywood Brown if he will unmute and turn himself on. Dr. Brown, are you there?
Yes, I am. Can you hear
Hi,
me?
Dr. Brown.
How are you?
I'm good. All
Great.
right. Are his slides loaded so that he can rock and roll?
Do you have his bio?
Yes. I want to make sure we were all ready to roll. Okay. I am very happy to introduce Dr. Haywood Brown this afternoon. Dr. Brown is a maternal and fetal medicine specialist. He's a graduate of North Carolina A&T, followed by his medical school education at Wake Forest, then followed by his residency at UT Knoxville, and finally completing his maternal fetal medicine fellowship program at Emory University Grady Hospital. Now, Dr. Brown is a renowned specialist in his field and has been an academic leader serving as chair of OBGYN at Duke for many years and is now at the University of South Florida. Dr. Brown is especially committed to the care of women at high risk for adverse pregnancy outcome, particularly those marginalized, and the impact on racial and economic disparity in maternal and infant morbidity and mortality. Dr. Brown is a past president of the American College of OBGYN, and during his presidency focused on disparity and women health equity issues. Without further ado, I turn it over to Dr. Haywood Brown.
Thank you very much, Barbara. And also, I would like to thank the Trust for allowing me to present to you all this afternoon on a very passionate topic. I've so much enjoyed all of the presentations today, and I had so many questions myself that I hope to get answered. If I could have that next slide, I'd appreciate it. Thank you. So when we think about contributors to health and healthcare inequity, particularly women's health, I want you to take a look at this because we talk about disparity and we talk about the clinical encounter. The clinical encounter and what the patient faces when she goes into the office is so important. How the provider communicates with her, what the cultural competencies of the provider's staff. Patient level factors, you've heard a lot about that already. What their beliefs are and their preferences are. Race and ethnicity clearly play a role in the disparity, as does culture and family. Education levels and resources available to them, which have become more prominent now during COVID. And biology when it comes to things like preterm birth. Provider factors. It's important for the provider to be knowledgeable, and that provider's attitude and the implicit and explicit biases that women in women in particular face in the healthcare system. And then their health system factors such as the Health Services Organization, financing as we talk about Medicaid, delivery, things you'll learn a little bit about with the Affordable Care Act and essential health benefits that I'll talk a little bit about, and the organizational culture. Next slide. But these are structural factors that I think we can all have a thought about. The economic gap is one of the most significant factors to health disparities in maternal child health. The stability of housing and food security has been raised even more by COVID. And of course, racism, even though there are some people who say that there's no such thing as systemic racism, certainly racism in healthcare has been a factor that relates to disparity. Next slide. And you can move on to the next slide. I basically just try to highlight that so that these will be the points that we'll make. Next slide. And the next. So when we think about racial and ethnic disparities in OBGYN, we talk about things like infertility, unintended pregnancy. We'll talk a little bit about preterm birth. We need to understand that the rate of stillbirths, for in fact, in Black women, particularly Black women who are obese, is significant. We've talked about obesity already. And so when we think about things like who should have early inductions because of risk, these, and when I say early term inductions, these are factors that we know now, particularly for obese Black women. I talk a lot about maternal death, even though it's a rare event, because it's so much more common in Black women than it is in white women. The incidence of sexually transmitted infections, we've already talked about breast cancer deaths, not necessarily breast cancer diagnosis, but breast cancer deaths clearly being disparate in Black women compared to the other groups that you see there on the slide. Next slide. This is life's work for me. And the US has a higher maternal and infant mortality rate than any other wealthy country. And so when we look at maternal mortality at being 20.7 deaths per thousand in 2017. Now, some politicians would say it's just 900 women a year, but I'm going to share with you the fact the disparity in Black women, regardless of what side of the socioeconomic ladder they live on, leads us to think that this is a problem that we must deal with. And the implementation strategies are very important. And in spite of the fact that there have been a lot of high-profile cases, it really is a challenge to all of us to look at the factors that impact overall maternal health, particularly in women of color. As does that go, it also goes with infant mortality, 5.8 deaths per thousand, but it's highest in Mississippi, where it's 8.6 per thousand. Let me share an analogy with you. Next slide. So if Mississippi were a country with this current infant mortality deaths, it would be somewhere between Botswana and Bahrain, countries away from the United States, in the Middle East, and in Africa. So just think about that. Think about that. Next slide. So what are the etiologies of disparity in maternal mortality? Why are American Black mothers and babies at risk? Why are we in a crisis? Next slide. So here are the data. If you look at maternal mortality by all races, you can see that it is it's low, but significant when you think about Black women at almost 50 per 100,000 or 42 per 100,000. And that is the top line. And second highest maternal mortality is in Native American women, white women. And why is it that we see the Hispanic paradox, where Hispanic women are probably at a lower risk for maternal mortality and a stable risk? We do know that when they do have a pregnancy complication, it's a lot higher, but the risk of death is clearly not as paramount it is in Native Americans and Black women. Next slide. Now, these are the things that we know we can do something about because we've done that through patient safety bundles. Obstetric causes, we've decreased the number of deaths from things like hemorrhage, blood clots, and preeclampsia and sepsis. Next slide. But these are the social factors. We did a study years ago that Black women were less likely to wear their seatbelts during pregnancy. And one of the factors, again, that contributed to their lack of seatbelt use was them having BMIs over 40 in their third trimester of pregnancy, just because of discomfort. Keep in mind that domestic abuse and homicide are leading causes of maternal mortality in Black women. These are social factors. And suicide is one of the leading causes of maternal mortality in white women. These are things that we have less opportunity to deal with, but we need to deal with them in our community as there are major factors, as is substance abuse. Next slide. Next slide. What we've studied and what we've looked at is the preventability factors. And what we've uncovered, in fact, is that cardiovascular disease is one of the leading causes of maternal mortality in Black women. Something called cardiomyopathy, in fact, where the heart enlarges and is associated with being older, being Black, and being overweight. And this is a leading cause for maternal death for women over 40, and particularly cardiovascular disease in Black women. And so while it may not be preventable as some of the other factors are, we know that preventable deaths from preeclampsia and hemorrhage and venous thromboembolism are clearly factors that we can do something about. And these are the things that we try to work with our patient safety bundles. Next slide. But understanding disparity in the big picture really looks like this, and not to confuse you, but look at things like that we know. Certainly you see poverty, you see institutional racism, you see the environment, you see education, you see literacy and language. But one of the biggest factors we have to deal with is fragmentation of care. The days are gone where a person goes to their OBGYN, she sees you the entire pregnancy, and they're there to deliver your baby. This is not the case anymore. Most of our care is delivered at clinics or in academic centers and offices. And then there's a group of providers that provide that care at the hospital. And the disparities, in fact, come from those fragmentations of care, in addition to factors that we know, including comorbidities. Obesity, hypertension, and diabetes also contribute to adverse outcomes for women who are pregnant. Next slide. The other factor is that the vulnerability of our population, particularly for Black women. The U.S. could avoid about 40% of maternal deaths if all women had access to quality care. Quality care is what we're talking about. Going to your prenatal visit is more than dipping the urine, checking the blood pressure, and not really asking the questions that we need to ask. And empowering women to have shared decision-making is very important, even when it comes down to things like induction of labor or cesarean delivery. But I say again, when you look at the bottom of this slide, Black women die at a rate of 3 to 4 times higher than white women in the United States. And 60% of those deaths occur in the postpartum period after discharge. Next slide. Now, the other issue is maternal infant mortality. Look at the gap there from disadvantaged women compared to wealthy women. And these are infant deaths over the course of 1 year. And you can see that the wider the economic disparity, the greater the risk that the infant would die within the first year of life. And we've talked about that in certain states. Next slide. I show you this slide because the leading cause of infant mortality in Black women is actually prematurity. And so when you look at the March of Dimes, which we work with, you can see that the largest infant mortality rates are in the southern states. Now, this is going to become even more of an issue when we understand that these are also the states that refuse or decline to expand Medicaid, that exclude or decline to expand Medicaid. Let that sink in. And so if you think about this, highest infant mortality rate, highest maternal mortality rates are in states like the one that I live in Florida, where we actually have a C in infant mortality, but we still have not expanded Medicaid. Next slide. Now, the factors that account for prematurity differences in low-risk women, whites versus Black, is stress. Their current health status, childhood and adolescent health history, the stresses that increase your inflammatory cytokines, just like we now know that prematurity is a risk factor for later development of adult women's heart disease. Nutrition, going into the pregnancy anemic, not taking a vitamin, your parents' and your grandparents' socioeconomic status, and the quality of medical care during pregnancy. So when we begin to think about all of these factors put together, they contribute to the disparity, not just in infant mortality, but also the factors in maternal mortality. So even though you may be at social and economic advantage, there are factors here that play a role in regard to those stressors. Next slide. And so these are the states that had expanded Medicaid as of 2020. You can see there's still 13 states. And if you flash back to the previous slide, you can see that many of those are indeed southern states, and they have not yet to adopt Medicaid. If you go back to my prematurity slide, which is 2 slides up, you can see how they compare with regard to this. Again, it's a mirror image of risk factors. Next slide. Next one. So the other issue that we have to deal with, particularly in the South, is that many of the states that did not expand Medicaid is where our rural hospitals are being closing. I listened to the debate last night between Jamie Harrison and Mr. Graham. And again, just understanding that the Affordable Care Act and what it was meant to do and why Medicaid expansion was so critical impacts these things. The things that we've been talking about today that contribute to health disparities in chronic diseases, diabetes, hypertension, obesity, much more common in the South where I grew up, and maybe in certain other states. But again, these things play a role in outcomes for mothers and babies. Next slide. Next slide. Now, the other thing is inequity and inequality. Go back to the previous one, I'm sorry. Previous slide. So 67% of Black women surveyed reported race-based discrimination at family planning visits. Many were rooted in racial stereotypes of reproductive behaviors, multiple sexual partners, and so forth and so on, which is just not true. Much qualitative and quantitative work describes that pressure women of colors perceive to use certain types of birth control. If you're poor, they like to make sure you're on birth control. They don't want you to have a lot of kids. And this goes back to even the funding for Title X, which was done by Richard Nixon, which gave affordable contraception to all women, which is now trying to be wiped out by the current administration. Now, he did it on the basis of racism. He did it on the basis of the, quote, welfare mom. But it turned out to be at least important for all women to have access to affordable and available contraception. And this is something that was guaranteed under the ACA. And you don't need to listen to me to know how much there has been trying to tear down the ACA and not give women choice, particularly Black women, women of color in rural communities. Next slide. Now, this is our legacy. This is a slide that I show because of the eugenic sterilization that occurred in the United States. And these are the number of states that actually had eugenic sterilization programs. You may have heard a lot about that in the state of North Carolina, where I grew up and lived in. And this was in 1935. Next slide. So mistrust is very important for us to understand. Between 1909 and 1975, physicians performed more than 60,000 forcible sterilizations in government organized programs. Now, there's a big thing going on right now that you've heard attention to. Non-board certified OBGYN, I think, in the state of Georgia, who is doing unnecessary and absolutely outrageous things to incarcerated women. 31 states, 7,600 sterilizations, 40% of them were minorities, mostly Black women. In Puerto Rico, it was a third of women of color. And in the Native American community, 25% of Native American women between age 15 and 44 were targeted for coarse-count sterilization during the 1970s. We still have to overcome these things. Next slide. So health equity. We did an analysis of about 24,000 women on Medicaid and the predictors of not attending a postpartum visit, which is one of my themes, was Black race. You've already talked about alcohol and drug abuse, mental health disorders such as depression, and then women living in neighborhoods where a high proportion of individuals greater than 25 did not have a high school diploma. So ensuring that all women were engaged in the support they need following birth is an essential step in achieving health equity, which is what my group and my initiatives have dealt with. Next slide. The other factor is that up to 70% of women, and you may have heard of gestational diabetes, who develop diabetes in the pregnancy, will develop diabetes themselves within 22 to 28 years. And depending on who you are and what your other risk factors are, you may develop it earlier. You can see that in Latin American women, gestational diabetes leads to diabetes within 5 years of the index pregnancy. And so we talk about diet, we talk about exercise, we're talking about preventive therapies. These are the things that we need to do. But here's the problem. Next slide. Now, the other thing we know is that there's certain risk factors that lead to cardiovascular disease later in life. I'm a member of the cardio-obstetrics group because we've now linked certain pregnancy complications like preeclampsia, preterm delivery, and having a small for gestational age baby to later development of cardiovascular disease. And this may be because almost all of these conditions are associated with some type of inflammatory cytokines. Think about what I said. Stressors and preterm delivery, stressors acting on the smooth muscle of the uterus, just like it acts on the smooth muscle of the heart. So cardiovascular disease later in life is comparable to obesity and smoking when you begin to think about these type of complications. It also is important for us to recommend annual blood pressure follow-ups, fasting glucose, lipids, and BMI on all our patients annually. And one of the challenges that we have dealt with in the world is that because women equate going to their gynecologist with having a pap smear, and the pap smear guidelines have changed, they make an assumption that they don't need to go to that gynecologist for their well women's visit. We need to also practice periodic screenings, particularly if you've had these type of complications. It's so important for you to have that blood pressure check, have your lipids checked, have your BMI evaluated, achieve a healthier weight, and do depression screening at every single visit. In fact, the majority of women see their gynecologist as their primary care physician unless they have other medical complications. Next slide. So the critical factors as I finish up is system awareness. Awareness and access to risk of pregnancy complications without promoting fear. Education of patients and providers, and shared decision-making in obstetric care and including contraceptive options. Aware of institutional biases that impact obstetric care at any level that might impact quality and safety. Adapt and acquire adherence to best practice guidelines. We need to follow the evidence. And this is something that's been mentioned by all of my colleagues thus far in that presentation. follow the evidence, protocols, guidelines, and safety bundles to reduce risk for morbidity and mortality. The good news for us is that the Joint Commission initiated 2 types of things that relate to obstetrics this year. And that is every hospital must have a hemorrhage protocol and every hospital must have a hypertension protocol to deal with most of the 2 most common causes for maternal morbidity and mortality during pregnancy. And all hospitals should have a thromboembolic protocol. If our one of the most famous women in the world can have a complications from pregnancy, like a major event, like a pulmonary embolus, you know it can happen to other people. And all they needed to do was to follow the cookbook that was out there. So adequate resources for safe and supportive obstetrics, team training, simulation, obstetric emergencies, but most importantly, accountability. And final slide. I think I have one last slide coming, and I think that's it. So with that, this is a quick run through of all the issues related to maternal and child health that I'd like to address with you, but more importantly, to talk about what we can do and what you can do to make sure that you get the best care during your pregnancy and that your infant gets his best care after birth. Thank you.
Thank you, Dr. Brown. Outstanding. It's Dr. Maxey on. I can go ahead and present a question. Dr. Norbert, you're muted. Okay, we'll wait for Dr. Norbert Stevens to come on. Simon, can you unmute her? Dr.
Okay,
Norbert,
here I am. Sorry about that. Dr. Brown, thank you so much for this very timely discussion. I meant to mention, talking about famous people, I was saddened to see that John Legend and his wife suffered infant loss or fetal loss earlier this week. So we're all subject to these tragedies. And hopefully the information that you shared with us that goes out into the community will help raise the awareness so that families can be more aware and able to address, be more partners in their care team. Now, I would like to ask you a similar question that I asked Dr. Walker. Let's say that we have a young pregnant woman. This is her second baby. Why should she not assume that she knows everything that she needs to know about being pregnant, since this is not her first time? Because I've had patients say to me, I have no need to go to prenatal visits. They're not going to tell me anything different than what I heard the last time.
Well, the most important thing is that every pregnancy is different. And one of the things that really is so important is when they get that postpartum visit and we go through risk factors, she may have had a preterm baby. And so in reality, we know that we can do a lot of things to decrease her risk for having another preterm baby. We know if she's had preeclampsia, she has a higher risk for it occurring again. We know if she's had gestational diabetes, it has a higher risk for pregnancy again. And so the idea of discussing those type of risk factors with her is so important. We also know that she gained an excessive amount of weight during that first pregnancy and didn't lose that weight between the second pregnancy. Now her risks go up for all of those complications again. And so these are the factors. The pregnancy could, every pregnancy is different. And just because things turn out, quote, okay the first time, as a patient told me, all my babies are 6 pounds. So why should I worry about this one? Because that baby is small for gestational age, as you know, and that is a risk factor for other things. And so the other thing is that, so this is the reason they should go. And also education share decision making so that you and your provider can make those decisions together. I always ask the patient and her partner, for instance, why is it you don't have any questions for me? And if you don't have any questions for me, then I have some for you. What did I say? Why is this so important? So prenatal care, as I said, is more than dipping the urine and checking the blood pressure. It's about quality. It's about quality and shared decision making. And so that's what I tell my patients who say, I don't need to come back. But it's so important that we do that also at the postpartum visit and have that postpartum follow-up. Think about it this way. I discharged a patient from the hospital who has had a postpartum hemorrhage. She's lost a lot of blood and she may not have gotten transfused, and her hemoglobin is down to about 8 when she goes home. If she doesn't have a pregnancy spacing and appropriate contraception, by the time she comes into the next pregnancy, she has a crit of a crit less than 30. So she's already starting out with risk factors. And this is the reason that becomes a real issue.
Thank you so much, Dr. Brown. I know that the chat box is blowing up. Michelle, could we have one question and then we're going to bring on Mr. Brooks?
Absolutely. Thank you, Dr. Brown, as well. So the politics of right to left seems to use Black women as the cause of deaths in children through abortions. Do Black women have more abortions than any other group, or is that just fake news to raise campaign money? Your opinion?
Total fake news. Total fake news. And in fact, we're at the lowest adolescent pregnancy rate in all races in 30 years. We're also at the lowest abortion rate in 30 years. And so when we begin to think about that whole push that says that we're killing our baby, they're really not concerned about Black women and their babies. They're concerned about, I don't need to, go there with you because it's a movement. But here's the challenge. Think about it this way. They're against contraception. They're against abortion. They're locking kids in cages. So do they really care about infants? Do they really care about Black infants? Do they really care about the states that need to have expansion of Medicaid so that we can make sure that infants are taken care of and mothers are taken care of? Do they really care about the essential health benefits that are under the Affordable Care Act by President Obama, which guarantee women breast cancer screening, pap smear screening, affordable contraception, and the ability to choose their provider? Do they really care about those things? So I would say that my long and short answer is that is an absolute myth propagated on bad principles. And in fact, the majority of women, as you may say, who have abortions, or as a percentage of the population, is what the percentage of the population really is.
Dr. Nabert Stevens, I have to ask this gentleman a question. Are you saying that our august country, our democracy, our republic, was somehow picked out people of color to be against? Is there a conspiracy of sorts, whether it be COVID, whether it be the child maternal mortality? Is there something against this group of people? That couldn't be, could it?
Well, I would tell you that policies don't lie. I spent 4-6 visits on the Hill with my colleagues when I was president, from internal medicine, from pediatrics, from psychiatry, and we were all there lobbying for maintaining the ACA. And of course, you know what's going to happen in a few weeks after the election. You talk about all of the pre-existing conditions that we have and the fact that people want to deal with the ACA. And just look at the states that have not expanded Medicaid. So again, it is a target. It is a target. Just like Richard Nixon targeted women of color for affordable and available contraception. The reality is it turned out to be a good thing, but his reasons were flawed. His reasons were flawed. And so these are the type of things that we have to continue to fight for. And I saw someone in the chat say, vote, vote, vote. It is so important that you vote and you really just undo the harm that's been done recently is a challenge. And we talk about people have already addressed it with COVID. We've already restructured prenatal care and postpartum care using telemedicine, for instance, so that our women don't have to come into the office if they don't have to. And so these are the type of things that we need to continue to be able to fund as well.
Thank you so much, Dr.
You're very welcome.
Thank you, Dr. Brown. Thank you, Dr. Maxey. Now we're going to have our weekly words of wisdom from Mr. Carl Brooks. Mr. Brooks.
Good afternoon, everybody. In my 70 years on this planet, there's never been a more important time or more important vote than the vote that we're facing in November. There are things that are happening on a daily basis, a weekly basis, with the passing of Trustee Ginsburg, the coronavirus, the discrimination that's been discussed in so many different ways. If we don't do it for ourselves, we got to do it for those that we love, our children, our grandchildren. We've got to make this happen. There's nothing cool about not voting. You're not tough when you don't vote. In fact, you're being a fool. We need to support and get out there and vote, not just for the president and vice president, but for the governors and police chiefs and all of those that have an impact on our lives. This is no joke. We've got to do it. We got to find a way of doing it safely so that we can make sure that our votes are counted. This is a critical time for the Black Health Trust. Since these programs began in the June timeframe, every Sunday at 3 o'clock East Coast and at 12 o'clock noon West Coast, we've been able to present this program with the baddest brothers and sister doctors on the planet. We've heard from everybody and we will continue to do so. We love it. We're getting better with our productions and everything is falling into place in a good way. But yesterday we spent time, about 3 hours, trying to understand how we put together a proper budget to continue doing this program, because our community will be impacted in a negative way if we can't be able to do it. We discussed things like staffing. We discussed things like equipment. We discussed the platforms that we need to focus on. We need your help. I'm not the kind of brother that want to beg anybody for anything, but we need your help. We need you to donate. And I'm surprised that with all the talented, supportive people that we've been talking to, somewhere between 7,000 and 10,000 people a week, that more haven't stepped up in order to donate to help this cause. This is our cause and it's for us. We need your help. Ain't no way of saying it in a cute way. We need your help. We need your financial support to help us. Look at our website and find all the various ways of supporting the Black Health Trust, and please step up and help us. Thank you very much.
Thank you very much, Mr. Brooks. Mr. Brooks is the past president of the Executive Leadership Council, which has as its membership the top Fortune 500 Black executives on earth. And we're very happy and proud that he has joined us to chair our Executive Advisory Committee. I'm so anxious to get to the questions, but I've got one more speaker who's I'm excited about. We're having a Tougaloo College reunion day, it looks like. And Dr. Jessie Sherrod has been a friend of mine since my own days in the Student National Medical Association. She has the distinction of being the first graduate of Tougaloo College to go to Harvard College of Medicine. She is in the Tougaloo College Hall of Fame. She's a board certified pediatrician and specialist in infectious disease and epidemiology. She is the founder of the Association of Black women physicians, and she is one of the early members of the Black Health Trust. As we speak today, I'd like to ask Dr. Jessie Sherrod to take the floor and give her presentation on outbreaks. Dr. Sherrod.
Thank you. Thank you very much, Dr. Maxey. Can you all hear me?
Yes.
Yes, ma'am.
Yeah, it is a pleasure to have the opportunity to speak before the Black Health Trust. I can remember back in February when Dr. Maxey had the vision, and I commend him for having the vision to put this together in view of the pandemic, the coronavirus pandemic. He sent a message to me, say, have Jessie Sherrod come to my office on Tuesday night. We're having a meeting. We have to figure out what we can do for our community during this pandemic. And it has evolved into the Black Health Trust, and it keeps evolving. I'm also esteemed to have the opportunity to be on the speaker panel with such outstanding speakers, and all the presentations have been excellent. And Dr. Maxey actually asked me to come on and talk a little bit about the fact that our Commander-in-Chief is now COVID-19 positive, and talk a little bit about the events surrounding his positivity. So I don't know if they've been able to get my slides together. May I have the slides up if they are together? If not, I can talk without the slides.
We have.
May we have the first slide? What I will do, because we've been dealing with COVID-19 quite a bit, I will be going fairly rapidly because most of this information you are familiar with. And I'd like to acknowledge the Association of Black Women Physicians because some of these slides came from their slide deck on coronavirus. So we know that coronavirus is a novel virus, and it has changed our lives. It has changed the world, actually. It's often called SARS-CoV-2, which is severe acute respiratory syndrome, COVID-19, and coronavirus. So I call it the virus with many names. Next slide, please. It is a respiratory virus, and it's in the family with rhinovirus and respiratory syncytial virus, which many of us have heard of before. It causes the common cold. We had our first epidemic experience with it back in 2003 with SARS-1, and then MERS in 2012, which most people don't even remember because it didn't have that many infections, 8,000 and 2,000. But now we have SARS-CoV-2, which is coronavirus COVID-19. Next slide, please. They are RNA viruses, and it's theorized that the virus came from China, from the wet markets. And there's a lot of information out there. There are a lot of conspiracy theories, but we'll just stick with the fact that it developed in Wuhan, China in December 2019 with a major outbreak, which they promptly controlled. And next slide, please. Transmission. And this is where I want to focus on. There are two major modes of transmission of this virus. One is respiratory spread, which is the primary mode of transmission. And then we have contact spread, where we have large droplets that fall on fomite surfaces, and you contaminate your hands by touching these surfaces. And then you can transmit the virus to your respiratory system by touching your face. And that's why we have the emphasis on first hand washing and then not touching your face so much. But the two major modes of transmission, the respiratory spread, within that has two major modes, and that's the large droplets, which you expel when you sing, talk, or cough. And then we have the smaller particles, which become aerosolized and which can actually hang in the air for extended periods of time. And then they are inhaled through your mouth and nose, and they land on your mucosal surfaces. Now, once you're exposed to the virus, there's an incubation period, which can range from 2 to 14 days. And, there's a lot of discussion now about the timeline of the exposure of our Commander-in-Chief, 45. And we are not yet sure exactly when he was exposed and when he actually first got symptoms. I actually, when I saw him on the debate on Tuesday night, he looked different to me, and he didn't look well. But at that time, I didn't know anything. I just thought maybe he had been campaigning a lot on the campaign trail and was a little bit worn out. But the medium time from transmission to the incubation period is about 5 days. Once you're exposed, within 4 to 5 days, you will begin to develop symptoms. Next slide, please. Now, we know that there are 3 main factors which determine whether you come down with an infection. A lot of people can go to the same event, be exposed, 3 people get the infection, the others don't get anything. So the 3 factors, the first major factor is the status of your immune system. Secondly, the amount of virus that you're exposed to, or your viral load. And thirdly, the virulence of the organism. And we know that COVID-19 is very virulent. It affects every organ system, including the brain, and it can really wreak havoc on your system. And I'm just praying that I never get COVID-19. And I'd like to, at this time, extend my best wishes to those people who have contracted the virus and who are now in treatment for full recovery. But the status of the host immune system is very important, because the severity of your illness really depends on your underlying immunity. If you have hypertension, diabetes, obesity, asthma, and COPD, all of those are factors, nutritional deficiencies, and then emotional anxiety and stress. Stress is a major factor in most illnesses, and you've heard that throughout these presentations. Now, one thing I want to go back to, because even on the presentation on cancer, we talked about obesity, when we talked about prostate cancer, when we talked about breast cancer, when we talked about maternal and infant mortality, maternal outcomes, obesity was a major factor, and that's because obesity is a state, it's an inflammatory state itself. And what one study has shown from Mass General, and this is recent, within the past month, that they did a study on children, and they found out obesity was a major predictor of the severity of the disease in children, even over asthma, which is another underlying comorbidity. So obesity is a major factor, and it's a major problem in our population. We have to work on prevention. We gotta take individual responsibility for our health, and also work to get the systemic elements and social determinants surrounding our health in place so that we can live healthy lives like everyone else. Now, the length of exposure or the contact time that you have with a person who is infected affects whether you come down with the infection. Next slide, please. Now, clinical presentation, we know, and I'm not going to dwell so much on that, because we all know that lung presentation is a major one, and the virus likes to get into the respiratory system by attaching to the ACE receptors. And 1 second, let me just, I have to call back. We know that asymptomatic people are the people who are most likely to spread the disease. So you can have asymptomatic. Hello, LaTanya, can I call you back?
Sure.
I'm doing a presentation.
You're doing a presentation. Okay, then how soon can you call me back?
It'll be an hour or so.
All right, because we got a deadline. All right, thank you.
Sorry about that interruption. So the asymptomatic person, it can actually still spread the virus. That's why you have to follow all of your recommendations of wearing your mask, washing your hands, and social distancing. Those are the 3 major public health measures that have been shown to work over centuries. And one of the problems I think that occurred in the White House situation is that they were utilizing testing as opposed to the regular public health measure, or not in combination with the regular public health measures, that has led to widespread infections surrounding people in the White House. and on the campaign trail with our commander-in-chief. So we have the pre-symptomatic time, and that's the time 2 to 3 days before you come down with symptoms when you are silently spreading the virus and you're highly contagious 2 to 3 days before you come down with symptoms. And of course, we have the symptomatic adults and the children. And let me just make this point about children, and I don't want to dwell on that, and we will have other slides coming up. But may I have the next slide though? With children, they tend to carry the virus in their nose in high concentrations. And this study from Mass General has shown that the viral load in kids' noses are more than the viral load of an adult patient in the ICU intubated with COVID-19. That's how many viruses. So the kids are like little petri dishes. They're walking around with all of this viral load. And of course, we don't know that much about spreading it right now because what? The kids were let out of school when the pandemic hit. But we know from previous studies with kids in daycare, infections in daycare centers, that kids spread infections, respiratory infections all over the place all the time. So I'm thinking there's gonna be, and we'll have to document that kids are gonna be a major factor in spreading the virus. Right now, the group that's spreading it the most are the ones that are between the ages of 20 and 48. And those are the people who are out and around and about and bringing it back home to the elderly people and to the kids. Now, the signs and symptoms, we know COVID-19 pneumonia, and then we go on to the unforgettable cytokine storm where you get widespread inflammation and thrombosis. And this is what leads to death because there is a hyperreaction of your own immune system in trying to fight the virus. Now, we talked about the importance of the immune system. And remember when the president came down with COVID-19, what was the first thing they did for him? They boosted his immune system. They gave him Regeneron. Nobody had even heard of it. Regeneron was polyclonal antibodies. They are taken from convalescent plasma and made into a drug. They're supposed to be stronger and cleaner in that they don't have all the stuff in the blood of the patient that donated the plasma. So it's a concentrated effort, boost to the immune system, which he got before he left the White House. Then they came along with remdesivir, which we heard about earlier, which will decrease the viral load. And so the symptoms of fever, fatigue, dry cough, anorexia, loss of smell is a major one, it seems. And it can present depending on the underlying status of your immune system. So we're gonna move, and I know I have to move kind of fast because, next slide, please. Now, cytokine storm, we talked about that. We're not gonna go into detail. Next slide, please. Next slide, please. And I don't want to dwell on children today, but one thing I have to say is that the reason kids are more protected, even though they have these high viral loads, is that they have their receptors, their ACE receptors in the nose have not developed. They haven't developed as many as adults have. And that is a protective mechanism for them coming down with the infection. Next slide, please. We talked about a clinical presentation. In kids, we know that Kawasaki-like syndrome is the major presentation that we've been seeing, and there can be some mortality associated with kids, and there's a high incidence of infection of the heart, which is myocarditis. So we have to be aware of that. Next slide, please. Now, I want to get to talk a little bit about, I'm not going to deal with this. We know that you can viral shed for up to 20 days, a maximum of 37 days. And you heard a lot about flattening the curve, and that was so that our healthcare system could deal with the outbreak and have proper care and beds, hospital beds. So you have to control the epidemic so that you're not overwhelmed and have no place to treat all of the people that are coming down with the infection. Next slide, please. Mitigation. Now, when we talk about mitigation, is how do we control this pandemic? And I must say that I have been very frustrated. I've been angry. I've been upset with what I've seen go down in these United States of America. And I hate to say that, but I am. This is my specialty. I was on the advisory committee on immunization practices at the Center for Disease Control, and I had high respect and high expectations for the Center for Disease Control. And I've been really disappointed at what has happened in America here. We have over 200,000 deaths from COVID-19. There's a government responsibility. They are supposed to provide leadership, clear, consistent messaging, and testing, contact tracing, PPE, isolation, quarantine, treatment, and therapy. And there's one Harvard professor in the School of Public Health who said early on, if we can do these 5 things and get them going from the national level, if we can do testing, contact tracing, isolation, quarantine with your social distancing and your mask, we can get this epidemic under control. But we never got that coordinated effort from the top. You know, COVID-19 became a political football. You know, it's the Democrats and the Republicans. And it's just really unfortunate because Black people are suffering, Latinos and Asians much more disproportionately than the Caucasian population. But nobody should be suffering under those kind of circumstances. Then we have the personal responsibility, and that's your responsibility. You have to wear your mask. I mean, I cannot believe the outcries about masks. What is it with wearing a mask? You know, we are so spoiled in the United States of America. Hand washing is the most effective method of infection control. So you need to wash your hands frequently, or if you don't wash your hands, use the hand sanitizer. And we know that hand washing is more effective than the sanitizer itself. We have to disinfect surfaces frequently, and you must do the social distancing. And 6 feet is the minimum. That's for when you are standing still. If you're out behind somebody that's jogging, you need to make that distance more than 15 feet because they've demonstrated that you can actually get the wind from that person running ahead of you coming back on you. So you want to spread out a little bit more. And then remember the 3 C's: avoid crowded places, confined spaces, and close contact with non-household friends. Right now, that's one of the major modes of transmission is family gatherings from different households. And we talked about the mask. It's been documented that the surgical mask, not even the N95, the surgical mask prevents infections 90% of the time. So you need to wear your mask. And of course, we've been through the safer at home with isolation and quarantine. And, you know, we may have to go through that again. We don't know what's coming up with the flu season, but I tend to think I have a positive outlook. I tend to think we're going to have less flu this year because we're already experiencing exercising respiratory precautions. Next slide, please. Now, testing, and I want to talk a little bit about this because, see, this testing was being used by the White House, the rapid test. We have 3 different tests. We have the viral test that will detect viruses, and those are the molecular test and the antigen test. They are PCR tests. One is a rapid test, which you can get the results within an hour. The molecular test takes a little bit longer. It takes days to weeks to get the results. The White House was using the rapid test by Abbott to test their people. Now, the problem with the rapid test is that it will pick up the positive, but it has a high false negative rate. So if you test negative, it does not mean that you don't have the virus or you're not carrying the virus. So you need to be retested. But this was their main mode of control instead of using their mask along with the test and social distancing. And we know that the Rose Garden event that occurred on Saturday, where they introduced to be judge for the Supreme Court, there were 8 people who came out of that particular event with a positive test for COVID-19, including the president and his wife, the ex-governor of New Jersey, 3 senators, 2 journalists. And so we're thinking that that may turn out to have been a super spreader event. And if you notice, if you go back to television and watch, you'll notice that there weren't that many people wearing masks. People were talking to each other right up in their face. They were hugging, they were shaking hands. So that is not what you want to do. So that is a good example of the misuse of just the test itself, the rapid antigen test, when it should have been used in combination with masks and social distancing, and perhaps we could have prevented all of these people getting infected. Now, next slide, please. The antibody test, I forgot to talk about. The antibody test does not tell you whether you actually have the virus now. It tells you whether you have had experience with the virus by your antibodies. And it usually takes from 10 days to 2 weeks to get a positive antibody test. Moving on to the next slide, please. I think the point that I want to make, and I'm not going to go into the racism because we know that we are disproportionately affected by almost everything in this system, because the system was designed that way. You understand what I'm saying? We have to redesign a system that addresses our problem. This system was not designed to address our problem. Next slide, please. I'm not going to go into detail about racism and public health, but this tells you and shows you how we are being affected. Next slide, please. So what I want to end with is to say, wear your mask, do your social distancing. Next, go on past these slides, please. Next slide, next slide, next slide. We have to have economic resuscitation, but we have to educate our family members and the public, and that was one of the purposes of this particular forum, was for educating the public and trying to get to our people so that they can understand what they need to do in order to protect themselves. And of course, I have to ask everybody to ask this question: what role are you playing in eradicating racism? And are you allowing yourself to be manipulated against your sister and brother? Because that is also characteristic of the system, and we usually call those people Uncle Toms. Now, next slide, please. Register and vote, and that's how I would like to leave you with. Everybody need to register and vote to try to change the culture of the United States, because I think not only are we at risk, but our democracy, our democratic system is at risk right now. And thank you so much for this opportunity.
Thank you so much, Doctor. I appreciate it. I'm going to stand up and cheer for your astute presentation, Dr. Sherrod. We've had so many good speakers, and we want to get to the question box as soon as possible. But it is very important that each of you share your posts of these events so that we can grow our audience. I understand there's a little thumb at the bottom, and please press the thumb up. And we want you to like us. If we are bringing value and knowledge and information to you by our physicians and healthcare providers, we appreciate you showing that. Dr. Sherrod, you have so many items that we can question you on. What I want to do is get to you, Dr. Brown, Ms. Wafer, and Dr. Haywood Brown as well with our questions. Michelle, do you have some questions? I want to go to Dr. Sherrod first and then others. And if everybody could make their responses as concise as possible, we can get everybody in to get the questions we have and try to meet our timeline.
Okay, thank you. And hi, Dr. Sherrod, nice to see you.
Hi, how are you? Thank you.
I'm good. So this one you spoke on a little bit, but the question was, could the children of Amy Barrett have carried the disease from Indiana and they were asymptomatic? So we're trying to figure out, I guess, if Amy Barrett and somehow her children were super spreaders potentially.
She's the judge candidate for the Supreme Court.
Whoa. That's a very good question. And, you know, I don't have the answer to that, but I think that's something that has to be investigated, because Barrett actually had the infection herself. She had, quote unquote, supposedly recovered, but we really don't know the status of her kids. They should all be tested. And I'm thinking that everybody who became, well, actually, you know, it's interesting because they had the rapid test. Those people who were going to be in close contact with the president were tested prior to this event with the rapid test. And if they were negative, they said you don't have to wear a mask. So I don't know whether her kids were tested and they were negative, but even so, the rapid test has a high false negative rate. And if you're negative, you could still have the virus. If you're positive, you definitely have the virus. But if you're negative with the rapid test, you got to do the molecular test to confirm that you're truly without the virus. But that's a good question. Those kids, they were there.
Go ahead, Michelle.
Okay, and so I have a question for Dr. Wafer. Can you tell me if the states determine which hospitals get remdesivir and how it's prioritized? Does Gilead have any say-so in the process? So again, if the question is, if the states determine which hospitals get remdesivir and how it's prioritized, that's the first part. And then does Gilead have any say-so in this process? This is for Deborah Wafer. Is she still on?
Yeah, she's still on. She needs to be unmuted.
There she is.
She's not unmuted though. She's not unmuted. You have to unmute her.
I'm waiting for Simon to unmute her.
Okay.
Let's go to the next person for questions and see if she gets unmuted.
Okay. All righty, for Dr. Doris Brown, what are your thoughts on dense breasts with regards to mammography? Should we demand an ultrasound each time?
Again, dense breasts, again, you need to get the 3D mammography, which is a tomos synthesis that will show you a little clearer what is going on. And if then it is not clear, go for the ultrasound.
Okay. And for Dr. Haywood Brown, it seems that Medicaid recipients have yet another strike against them when it comes to quality care. If you're a Medicaid patient, you just get medical care, not high quality medical care. Do you know if that's the case, that Medicaid does not offer high quality, high risk care, but rather just offers basics? Oh, we have to unmute him as well. Simon?
Can you please unmute all the speakers, Simon?
I'm so sorry.
Okay, is everybody muted? Okay.
Well, Deborah Wafer is still muted, and so is Dr. Brown, Haywood Brown.
Yeah.
I just want the speakers unmuted. In the meantime, go back to a question for either Dr. Sherrod or Dr. Doris Brown, so we can keep going and meet our timeline.
Sure. Okay, Dr. Doris Brown, let's see. How does a woman with 25 years breast cancer survivor go to a new diagnosis of leukemia? How are they related?
It depends upon the therapy. Yeah, I am mute. It depends upon the therapy that she received. There is an associated leukemia that can come with some of the treatment that you would receive for cancer. It's usually, it's another cancer, a second cancer that's called the myelodysplastic syndrome.
Okay. And Dr. Sherrod, thank you, Dr. Brown. Dr. Sherrod, can you say more about the cytokine storm?
Oh, more about the cytokine storm? Well, what happens is that these receptors, these ACE receptors are also, the virus attacks the endothelial lining of the blood vessels and creates inflammation, and you have activation of the platelets. They become hyperactive, and you get this hypercoagulable state. That means that you start clotting, and this total response is the immune system trying to fight off the infection. So it's like a revved up the body is fighting so hard that it begins to attack itself. And that's when you get widespread inflammation throughout the body, they call it disseminated intravascular coagulation. In bacterial sepsis, usually you bleed, but with this viral infection, you actually start clotting off things, and that's how you get stroke and all of that. But the cytokine storm is the immune system trying to fight off the infection and overreacting to the point that it begins to destroy itself.
Okay, and while I have you real quick, do you recommend the flu shot for youth with comorbidities such as asthma?
Well, you know, I think the flu shot is an individual thing, and I know that they are highly recommending it now, but I have to refer back to the data from Italy. Early on, we know that the flu was said to have increased the risk of coming down with COVID-19 in Italy. That was one of the postulations for why they were having such a hard time with it, because they have an elderly population and many of those people had received the flu vaccine. So I think it's an individual thing that you have to discuss with your physicians about whether you should get the flu shot or not. It is recommended if you have comorbidities, but I'm thinking that because we're practicing respiratory infection control, and if you're practicing your measures for COVID-19, that works against flu also. So we should have less flu this year because we are already practicing those social distancing, the mask, and hand washing. So you can talk to your doctor about it.
Okay, all right.
Very good. Okay, well, while we're waiting for the mute
Okay, I
technician.
understand that part of our system is down. Dr. Doris Brown, you have defaulted as the host. Can you unmute Dr. Hayward Brown and Ms. Deborah Wafer?
Kevin RT Calhoun MD.
So, Doris Brown, can you unmute the speakers? You're in control, Colonel. Don't ask me how it happened, but you are.
Yeah, you go into participants and they're alphabetically listed and you can unmute them that way. But I'm not a host, so I can't do it.
Dr. Brown, are you there?
She's there. She's on mute. She's trying to.
So you can go in, if you make me the host, I can go into participants and try to see if I
do
can.
that right now. She's the only one that can do it right now. I don't know why.
Dr. Brown, do you see in the participant at the bottom of your screen? Okay.
In the meantime,
If you click on the microphone, you can unmute this next speaker.
so
You need to unmute Deborah Wafer and Dr. Brown.
Okay. In the meantime, for our program next week, we're going to discuss nutrition, especially nutrition in the Caribbean. We understand that although COVID is a problem in Jamaica, it may be less than the problem we have here. We're going to have the speaker, Dr. Kervin Dawes, among others. We're going to have an interim meeting among our committee of medical advisors, coming to some decisions on not only the COVID vaccine, but vaccines in general. We hope to have soon a list of recommended healthcare reading and references on our website, as well as all of the documentation of our previous speakers. So we're growing and we do need your urgent support as we go on. Michelle, do you have a question for any of our presently unmuted speakers? And Simon,
Okay, Deborah is unmuted now. Deborah Wafer is unmuted, and Dr. Brown.
And Dr. Brown, yay.
But now Doris Brown is still muted.
So let's.
Go ahead.
I'm working. I'm unmuted.
I think Deborah Wafer has been waiting the longest.
Yeah, there's Deborah Wafer, yeah.
Yeah.
So my response in there as well for you all who asked a question about Medicaid. Again, quality of care is really not as much of a factor as access to care. And women on 50% of all births in the United States are on Medicaid. And so really only 50% of all counties in the United States don't have a practicing OBGYN or midwife. And still you're talking about women having to drive more than 30 miles to a delivery hospital and more rural hospitals. And so that impacts quality of care. And so the guidelines for perinatal care dictates the care for all women. But there's no question that there are still institutional biases around women who are below the poverty level. and poverty factors make you more eligible for Medicaid. There are many restrictions. In fact, Indiana has a work to Medicaid program. What happens is that many of these programs are eliminated in Medicaid in 6 weeks or 60 days. In Texas, for instance, only 17% of women continue to have their Medicaid after 60 days. And we know that this is a factor in ongoing care. And so these are the things that we're working on. That is extension of Medicaid to 12 months so that women can get their well women's visit. Very important stuff. So that's a long answer to what we're doing. Quality should not be impacted by insurance status. And it really isn't that as a factor.
Okay,
Thank you so much. Let me ask Dr. Wafer on. Can you ask her the question you had for her?
Right. Dr. Wafer, do you need me to repeat that question, that long question regarding? Okay. Can you please tell me if the states determine which hospitals get remdesivir and how it's prioritized? That's the first part. And then it says, does Gilead have any say-so in this process?
Yeah. So no, Gilead gave the drugs to the government, right? Then the government, the public health officials in the government moved the drugs to the states, and then the states moved it to the counties where the most people were impacted. So once the drug left Gilead, we had no say-so on who gets what. That was the first part of the question. What was the second part?
Second part, well, that you kind of
That was
answered.
the second part.
Yeah.
Okay, yeah. So once the donation was made to the Department of Health and Human Services, then Gilead was out of where the drug went. And I just know from here in Los Angeles that it went to LA, and it went to the state, then it went to LA County, and then it went out to the hospitals in surrounding areas where people were having patients. And if you were a hospital, say, that didn't receive a supply, then you could communicate with the public health department in your county and see if you could get some.
Okay, thank you.
Before I go to the speakers for a final question, we're at our close to our time limit where we have to sign off. I'm extremely concerned that we must take these challenges seriously. We're under attack as people of color. It is not even so subtle that we believe that forces are trying to let you die. Let you die.
Amen.
And we here at the Black Trust, and we also have a group called the Select Round Table, we believe that this is an unmitigated killer attack on people of color. They will kill white people in order to have you die. Do not think that this isn't pre-Nazi Germany. We think it's incredulous that our government could work against us, but we have to be wary. We have to have our act together. We need to be close to friends of ours that are friends of ours. I'm not saying anything about white people being bad. I'm saying our political system is bad on us. And many of us just can't fathom that any of this stuff is on purpose. But when you have so many things working against us, as Dr. Brown has talked, both Dr. Browns have talked about, Ms. Wafer, Dr. Sherrod, and other speakers, when this many things are pointing at you at the end of a barrel or a needle, don't think it's not on purpose. People are very smart. I'd like to recognize each of our speakers for a brief last word, and I'd like to express the Black Health Trust appreciation for each of you. Let's start from the beginning. Dr. Doris Brown, past president of the NMA.
Well, thank you again for inviting me, but know this, that we as a people have lived 83% of our 400 and few years under terms of Jim Crow and other presidential things, prejudice. So we are now removing or returning the clock, and we're going backwards. In 2042, we will not be the minority, we will be the majority in people of color, and forces are working hard to make sure that that does not happen. It's about economics, it's about resilience. We are very resilient people. If we join together and collaborate, we can withstand the economics of this and we will survive another 400 years. Thank you.
Thank you so much, Madam President. Ms. Deborah Wafer.
Thank you, Dr. Maxey. I just wanted to, I want to echo first what Dr. Haywood Brown talked about, and that's the Affordable Care Act. And when we look at the red states and who's dying, and in those states is where more Black people live than any place else. And I think that we, as Black people and as folks in our community, really need to rally and do something about making healthcare accessible to folks in those states. Those red states are killing Black people, essentially, is what's happening. And the other thing is that when we look at HIV, which is what I work in, HIV is a preventable disease. And don't know about PrEP, which is pre-exposure prophylaxis, and they don't know about PEP, which is post-exposure prophylaxis. And then if you don't have Medicaid or you don't have the Affordable Care Act is not available in those states, it's more difficult to have access to all of those things. So first, I'd just like to say that. And secondly, when it comes to COVID, I think if nothing else, we all need to continue washing our hands, wearing our masks, and educating folks about some of the distrust, mistrust, and the urban legends that are going on. And that's going to kill us more. And as one person said, let's don't let our denial be deeper than our grave about what's going on in the world right now. Thank you.
Thank you. Thank you very much, Dr. Haywood Brown. And I must say, you are a major cheerleader, my brother. Thank you for being here. Final word.
Well, I'd like to echo those comments that have been able to say, and I'm going to say something to this group. When it comes to what has happened with people's denial of systemic racism. I've mentioned Richard Nixon a couple of times here. Richard Nixon in the 1960s built for-profit prisons based on the birth rate of Black babies, Black male babies. Let it sink in. That's reality. So we should not be surprised by mass incarceration. Because it's a design thing based on the birth of Black kids who are living in poverty and so forth and so on with poor education. Now, we got to do something about it too. We've got to do something about it as well. When I talk about passionately about how important the ACA is, there are more beneficiaries of the ACA who are white than there are who are Black. That's the other issue. And when people are willing to vote against their best interests for health care, this is the reason that you got to send Jamie Harrison some money in South Carolina so he can take out Lindsey Graham. This is the reason you got to send Mike Espy some money in Mississippi, who's now tied with Cindy Hyde-Smith. Things can change if we vote. Think about how few more Black votes it will take to do what we need to do. We have to preserve the ACA for everybody. We have to preserve the essential health benefits. And I will say this, it's one thing, as our colleagues have said, to recommend that you go and get a mammogram, but you can't get it if you can't afford it. Do whatever the guidelines are. You can recommend colorectal screening now in women in Blacks who are under 45, but you can't get it if you can't afford it. And so that really is the issue. And that's my comment. That's my plea. Let's go to the Hill and let's fight again, because we're going to have to.
Thank you so much, Dr. Haywood Brown. We appreciate you. And for final brief comments, I recognize Dr. Jessie Sherrod.
Thank you, Dr. Maxey. And again, we commend you for your vision for this forum. And I just like to stick to my area with the COVID-19. I also agree with everything everybody has said, all of the previous outstanding speakers in regards to racism, because it extends across all diagnoses, because it's systemic. And I'm glad that I mentioned at my Harvard Diversity Reunion that I actually got up and spoke about systemic racism. That was in October last year, 2019. But we have to know that COVID-19 is real. There are some people who are still out there saying they don't believe it's real. If you don't believe it's real, give the White House a call. Okay, and we need to stop playing around with the recommendation to public health measures, wearing your mask, washing your hands, and social distancing. Those are all preventive measures. One thing that I would like to see us focus on is what we can do between the time that a person is infected, they go to the emergency room, they're mildly symptomatic, they get sent home with nothing. We need to come up with protocols to treat those patients before they get to the point of having to go into the ICU and then go on the respirator. And I told Dr. Maxey, I have a cousin in Baton Rouge who actually has developed protocols. He's an ER physician, and he's had nobody return after giving them these medicines that have not been randomized and trialed in a randomized controlled, placebo-controlled study. You have to boost up your immune system with vitamin C. Vitamin D is very important. Do you see that the president was on vitamin D?
Everything. He's on everything.
Too. And I've been preaching this, and they say, well, where's the data for zinc and where's the data for vitamin C? Well, it's out there. Linus Pauling did it years ago with vitamin C. So we need to boost our immune system, practice our infection control measures, try not to get COVID-19. You don't want it. We don't even know what the long-term effects are yet.
Well, thank you so much, Dr.
Yeah.
Sherrod. First of all, after I say I agree with 100% of everything that our speakers have said, my disclaimer is we're not allowed to talk politics, but I'm glad you did. Before we leave, a little history. I was born in 1941, and shortly after December 7th of 1941, Congress passed an act called the McCarran Act. That allowed the US government to legally intern Japanese Americans. Subsequently, in 1948, after the Detroit race riots, they passed an amendment to that, and this is all in the congressional record, called the King Arthur Amendment. This allowed, on the order of the President of the United States, that every Black person, regardless of rank, serial number, whether they were a doctor or a colonel or what, to be either imprisoned or terminated. This was reversed only in 1964. The main issue that I saw in that King Arthur Act, it said within 30 minutes after an order of the president. I'm going to use Dr. Haywood Brown's word, think about it. If somebody has a plan that can be enacted in 30 minutes, there is a mechanism for your extermination. Now, just because I'm not paranoid does not mean everybody's not out to get me. So we need to be very serious about the things we're hearing from our consultants. We need you to support the Black Health Trust. Next week, we're going to introduce several things we've done. We've worked on creating some of the solutions to finding cheap ways, not cheap, but inexpensive ways to do treatments, whether it be imaging for mammograms. We've joined a company called Self-Pay Medicine. We're going to have access to laboratory medical records. We're going to have access to things such as remote monitoring, pharmaceuticals for people who can't afford them. We're going to try to do our best from a medical standpoint. But all of us know that the real lesson we've learned is we must have economic independence. I thank you for joining us today. I'm going to ask for a brief word from Ms. Brenda Lee Yeager as we close.
Dr. Maxey, just before Dr. Brown, Dr. Doris Brown, did you have one final Anything you needed to
Yes,
say?
I just wanted to say that I know the current president of the NMA has created a task force to address COVID. I don't know the people that are on it, but again, it needs to be really pushed so that we can come up with answers for us, by us, so that we are not interred in 30 minutes.
Yeah, we
Thank you.
have a pending invitation going out to Dr. McDougall to select his person to come and speak to us in the not too distant future. So thank you on that.
Yes.
Ms. Ager?
Ooh, I had to take a breath. It's been great today, a lot of information, and I just want to close by saying I give thanks for who we are, and I give thanks for the information that we've not been getting, but now we are. So I just want to give thanks for the doctors, the speakers, everyone involved in the Black Health Trust. I'm so honored and grateful that I get to just watch and listen. So with this deep breath, I'm just gonna leave you with, I know there's a change coming because we're making it. So may God and all the angels watch over us and keep us as it's been keeping us. And we excel and we grow in grace, in beauty, in love, in education, in power, that we be who we're supposed to be, who we know who we are. And in that, we rest assured that the change is made, and it's made through us. So take care. We'll see you next week.
Thank you very much. And for our affirmation, Ms. Bailey?
I posted it in the chat. I'm going to read it. If you have good thoughts, they will show out on your face like sunbeams, and you will always look lovely.
Thank you.
Thanks, Tori.
So much, and I appreciate our guests for taking their time to speak to us, and we hope to have you back. And I thank our beautiful and smart hostess, Michelle. She is our professional at the job. We have to twist our arm every now and then. And I thank my co-moderator, Dr. Barbara Stevens. Thank you so much, everyone.
Thank you, Dr. Maxey.
Thank you, Dr. Maxey.
Thank you, everyone.
Bye, Doris.
Bye-bye.
Everyone.